So let's talk about something that happens to literally every medical trainee. You get a patient's lab report back and their liver numbers are off. What do you do? How do you even start? In this explainer, what we're going to do is break down the official ACG guideline into a simple, practical framework you can actually use on your next shift. All right, here's our game plan. We're going to walk through this just like you would in a real clinical setting. We'll start with the absolute basics, what these labs even mean. Then we'll figure out the pattern of injury, and from there, we'll dive into each of the major workups step by step. Okay, first things first. Before we even think about a differential diagnosis, we've got to get our terms straight. This is a super common point of confusion, but trust me, getting this right from the start is absolutely the most important first step.
Okay, this is probably the single biggest mix-up, so let's clear it up right now. The labs we call LFTs, like ALT and AST, don't actually test liver function. They're markers of liver injury. They tell you that liver cells, hepatocytes, are unhappy. If you want to know how well the liver is actually working, its synthetic function, you've got to look at albumin and the prothrombin time, or PT. And they tell you very different stories, right? Albumin has a 3-week half-life, so it's a marker of more chronic function. But PT, man, that can get prolonged in less than 24 hours if the liver's in serious trouble.
Now let's talk about what normal even means. I'll bet the number your local lab uses as its upper limit of normal for ALT isn't the whole story. The latest data suggests that the true healthy normal is actually way lower. Check this out. For men, a truly healthy ALT is probably under 33. And this isn't just academic. The guideline is pretty clear that anything above this is linked to a higher risk of liver-related mortality. That's a big deal.
And for women, it's even stricter. We're talking 25 or less. So what does this mean for you on the wards? It means a lot of patients whose labs you might have glanced at and called normal probably deserve a second look, especially when you factor in things like BMI, which we know has a pretty direct relationship with ALT levels.
Okay, so you've decided the number is truly abnormal. What now? Well, now comes the most important step, pattern recognition. Getting this right is the central decision point that's going to steer your entire workup from here on out. So what are we looking for? It really boils down to two big buckets. Is this a hepatocellular pattern, meaning the liver cells themselves are angry and inflamed? Or is it a cholestatic pattern, which points to a problem with the plumbing, the bile ducts? And if you want to get a little more scientific about it, you can actually calculate something called the R ratio. It looks complicated, but it's a simple formula. The bottom line is this: if that R ratio is greater than 5, you're thinking hepatocellular. If it's less than 2, think cholestatic. And that sweet spot right in between 2 and 5, that's your mixed picture. All right, let's start with the most common scenario you're going to see, the patient with a hepatocellular pattern of injury. So, when you see those mild bumps in the ALT, say less than 5 times the upper limit of normal, your initial moves are pretty straightforward. First, you've got to take a fantastic history. Ask about everything. Second, stop any potential offenders, alcohol, certain medications, weird herbal supplements. And then you order that first batch of screening labs and an ultrasound.
And this is basically your go-to differential for that initial screen. We're hunting for the big 5 here. Non-alcoholic fatty liver disease, especially if the patient has metabolic syndrome, chronic viral hepatitis, so that's your Hep B and C screen, alcoholic liver disease, drug or supplement-induced injury, which is why that history is so key, and finally, hereditary hemochromatosis, which is just a fancy way of saying iron overload. Okay, lock this one away because it's a classic board question and super high yield in real life, the AST to ALT ratio. In almost every other liver problem, ALT is higher than AST, but with alcohol, it classically flips. The guideline actually says something like 90% of patients with alcoholic liver disease will have an AST greater than their ALT, often in that 2-to-1 ratio or higher. It's a huge clue. So what happens if you've done all that, everything comes back negative, but those enzymes are still high? Well, now it's time to go digging for the zebras. This is where you start screening for less common things, like autoimmune hepatitis, Wilson's disease. That's a copper metabolism issue you really want to think about in younger patients, say under 55, and alpha-1 antitrypsin deficiency, that genetic one that can hit both the lungs and the liver. Okay, so you've run the whole panel, you've stopped all the potential bad actors, and you still don't have an answer. Where do you go from here?
This is the point where the guidelines say you should really start thinking about a liver biopsy. When all the blood tests and imaging just aren't giving you the answer,
or maybe you think there's more than one thing going on, sometimes you have to go get a piece of the tissue to see what's really happening at the microscopic level. All right, let's pivot. We've talked hepatocellular. Now, what do you do when the labs scream cholestasis, when that alkaline phosphatase is the one that's way out of proportion?
The pathway here is actually a really elegant three-step process. Step 1, confirm the alk phos is actually coming from the liver. It can come from bone, so a GGT level helps lock that in. Step 2, get a right upper quadrant ultrasound. And step 3, on that ultrasound, you're looking for one key thing. Are the bile ducts dilated or not? That ultrasound result is a huge fork in the road. If the ducts are dilated, big and puffy, you're thinking there's a blockage, a physical obstruction, like a gallstone or a stricture. That's going to lead you to more advanced imaging, like an MRCP or maybe even a procedure like an ERCP. But if the ducts are not dilated, that points you away from a plumbing problem and towards a medical or intrahepatic cause.
So if you've gone down that not dilated path and you have this intrahepatic cholestasis picture, your very next step should be to check an AMA, an anti-mitochondrial antibody. Why? Because you're screening for primary biliary cholangitis, or PBC. That AMA is the key test. It's positive in something like 95% of people with the condition.
All right, last major scenario. What about the patient who comes in and their ALT, AST, and alk phos are all perfectly fine, but their bilirubin is high, the isolated hyperbilirubinemia? When you see that elevated total bilirubin, there is one single, all-important first step you have to take. It's the test that's going to slice your differential diagnosis right in half. Any guesses what it is?
You have to fractionate it. You need to know if it's direct or indirect, conjugated or unconjugated. It's everything. Because if it's mostly unconjugated or indirect, you're thinking about relatively benign things like hemolysis or the super common Gilbert syndrome. But if it's conjugated or direct, that's a red flag. That almost always points to some kind of liver disease or biliary obstruction that you absolutely have to investigate further. So look, we've just walked through all these really nice, clean algorithms from the guidelines. They're evidence-based, they're systematic, but at the end of the day, they're just a guide. The most powerful diagnostic tool you have isn't an algorithm at all. And that's the real takeaway here. These guidelines are fantastic, but they're here to support, not replace your clinical judgment. Nothing beats taking a really thorough history, doing a careful physical exam, and then applying these frameworks to the unique person sitting in front of you. That's how you get to the right answer. Thanks for watching.